Hello, everyone. I'm Dr. Carmen Pugliafito, and today I have with me Professor Anat Loewenstein, who is a real pioneer in the field of home OCT. Anat, welcome to Retina Synthesis.
Thank you very much, Carmen. It's a pleasure to be here, and thank you very much for including me in this amazing series.
Yes. So, for those in our audience who might not be familiar with the concept of clinical management with home OCT, why don't you give them a basic tutorial?
I will. I'm happy to do it. So, the home OCT is a way to monitor the patients in between visits. Patients with macular degeneration, with neovascular macular degeneration, in between the visits. And nowadays, that we know that we have these very long-acting agents that allow 60% of the patients, 80% of the patients to hold longer. It's even more important because it's not 100% of the patients. So you need to find the ones that are actually amenable for the long-term extension. And the home OCT has even a greater potential than it had before. And the issue is that, we know while we've greatly advanced with the treatment of neovascular macular degeneration from the time from maybe 15 years ago, we know that still it's not optimal, and the treatment is not optimal, and it's not optimal in two ways. One of them is because the burden is nearly unbearable on us, on the system, on the patients, on their caregivers, on everyone. And second, because actually the final outcome is not perfect. Some of it is because the compliance is not perfect because of the burden, and some of it is maybe where we can do something a little better for the patients. So for many years, we've been working on the home OCT as a way to monitor the fluid of the patients in between scheduled visits. And the way the flow of this technology goes is a little complicated because it's not a technology, it's not a device. Rather, it is a whole healthcare system. The way that the flow goes is the ophthalmologist who remains responsible for the patient, as we want to be, sends a prescription to the monitoring center for the device. The monitoring center provides the patients with the home OCT and also the necessary support for the regular monitoring. First of all, for the mere establishing of connection to make sure that the images are readable, that they're uploaded on a cloud, and then also for the compliance and for the alerts. The patient's task is to perform daily OCTs, and these are automatically transmitted to AI-assisted cloud service for the analysis. The monitoring center cloud is actually completing the AI analysis, establishing the existence of hyperreflective spaces, both intra, sub, and total. And then the ophthalmologist can review them. So first of all, he can review them 24/7, and he also gets alerts. He gets alerts any way he wants to get the alert. He can get an alert if the fluid achieved a certain volume, or after a certain time, or both. Of course, when we are doing this near daily remote OCT scans, this is not feasible without AI, because physicians can practically review all the images that are required daily by patients. The technology actually involves also AI-based analysis that makes the review of all these large data sets feasible. So the patient is doing the daily scans. These are processed by AI for segmentation, annotation of intra, sub, and total hyperreflective spaces, which actually equals fluid. This is processed by AI to produce projection maps, and then to provide provide what we call actually the fourth dimension, that of time, by showing a trajectory of what happens during time. The technology itself is a very small device. It's compact. It's easy to use. Over the years, it took time to us for the company to develop the fully automated alignment that elderly patients can use, and then to achieve a quality that is similar to that of in-office OCT, which is only in the 3 millimeter region around the center of vision. And the technology uses connectivity, both cellular and Wi-Fi, to make sure that the data is transferred in a good enough manner. The physician, when he looks at the report, he can see the mirror OCT scan. He can see the AI estimation of the hyperreflective spaces. He can see the projection map, and then he can see the longitudinal fluid volume, and can set the threshold as he wishes. Over the years, we did a plethora of studies on the home OCT, and I'm not going to talk about all of them, but I'll just detail a few. One very important one was the one that was done by the DRCR-net, Protocol AK. Protocol AK of the DRCR-net is a protocol that looks at the feasibility of a technology. This is prior to establishing Protocol AO, which is now going on. That was for 6 months only, whereas the other one, the AO, is going to be for 2 years. Patients were given, naive patients were randomized to either being managed according to home OCT or just standard of care. And then the patients have weekly scan frequency was measured over these 6 months, time per scan, and number of scans eligible for fluid qualification were recorded. And the results were very good, showing a good fidelity. Patients did about 6 scans per week, which is almost every day. And the images were in 87% of the time, the scans were eligible for fluid quantification. By the way, the time of the scan is very short. It's less than 1 minute per eye, 47 seconds. When you looked, so first of all, for the AI detection versus reading center detection of the fluid, it was amazing. It was very good. There was a very large heterogeneity in between the patients. Some patients immediately lose all the fluid. Some patients have like a lumpy, bumpy course, which also gives a great potential to decide early on how to treat a patient. So the technology is very exciting, and the use of AI is mandatory and extremely exciting. And basically, the study that we did led to the FDA approval in April of 2024. And the reason that it was approved is because the pivotal trials were done that tried to see how accurate is the AI estimation and validation. Because if you are going to use AI, you need to show how valid it is. So one study looked at the agreement between the visualization of the hyperreflective spaces between the home OCT and in-office OCT, and the agreement, both for presence and absence of fluid, was more than 86%. It also looked at the repeatability. If you are doing the same test, a test a few times the same day, and then the variability was it was 11%, which is completely acceptable. The percentage of patients who were able to activate the technology among these elderly patients that we know was 96%. They did 6 tests per week, as was with the protocol AO of the DRCR-net. And the agreement between the AI and graders was higher than the agreement between AI and between graders and themselves. So these studies actually led to the FDA approval and are extremely important. There are multiple other studies that we did, smaller studies that showed, for example, a study that was led by Nancy Holkamp and Jeff Heyer that showed that patients who were treated, who were switched to being managed by home OCT, their interval between injections increased from 8 weeks to 15 weeks. Just because the granularity of the data allows you to extend in cases which you might be a little more reluctant when you don't have this very tailored knowledge about the patient. Another study showed that when where physicians were shown the home OCT data on patients whom they treated, who they treated not according to the home OCT, they treated them according to the office OCT, but home OCT data was captured. Then in about 50% of the patients, the physicians would have decided not to treat in cases where they treated, but when they treated, it was about a week earlier than they actually, when they would have treated, it was about a week earlier than they actually treated. So a lot of data that is captured here. So I think that we already have so much data and to show the validity and the importance of the technology. The main actually barriers of the technology is first of all just to establish the system, the healthcare system of who is prescribing, which is the physician, who is monitoring the compliance. It's the company's monitoring center, who is reimbursing the physicians, who is reimbursing the company. These things that will, of course, are very important in real life, actually are still in the process. And of course, we all look forward to seeing the result of Protocol AO of the DRCR-net, which will really tell us if when you use the technology on a long-term basis, if you are able to either lower the burden significantly in terms of number of injections, and or have a final better visual acuity. And the thought that you might have a final better visual acuity is that it is a PRN regimen, but the PRN is very accurate. It's like the minute you have fluid, you're treated. So hopefully we'll have a confirmation from Protocol AO of the DRCR-net, and all the technical and logistical healthcare system issues will be solved, and we will be able to bring this technology to all the patients who need it.
That's wonderful. In AO, they're using faricimab, correct?
Yeah, you are right. Of course, they're using faricimab.
Which is wonderful because they're taking one of the most durable agents
Yeah,
and looking at so you've got a state-of-the-art monitoring system with a
exactly.
second generation long duration molecule. So this is the ultimate test. The ultimate test.
Absolutely. It gives you a safety net. It gives you a safety net when you start to treat the patients. It gives you a safety net when you want to extend the patients. And sometimes if you also want to maybe stop the treatment, which we can do in some patients, So this is something that can be also in a way looked at. So hopefully, we'll be able to give our patients this opportunity.
So looking at AI, are you looking at different, more advanced variants of AI in this system?
Yeah, yeah.
Can you discuss that a little bit?
I think the issue of AI here is AI that looks at that is doing the segmentation, and that is doing the actually quantification of the fluid and the comparison. This is one thing, but I think what is very big about this technology, that the AI OCT analysis has been validated. And I think we hear about so much AI in OCT, but there is very, very little
Yes.
validation.
Yes.
Very little validation. And here it was validated in many ways. It was validated, as I said, and it was validated to look at the signal to noise ratio and give different thresholds when the signal to noise ratio is high, as opposed, we chose patients that are more maybe have a more variable amount of fluid as compared to patients that are very stable most of the time.
At the
So,
at the angiogenesis meeting, you gave an update on your latest work. Can you tell us a little bit about what you're currently looking at?
Basically, what we are doing now with the home OCT is to further validate the results of the home OCT to try and see that everything that we're looking there in terms of sensitivity and specificity are actually correct, and that we might be able to predict the response of the patients from what we are seeing in such a granular manner in the patient. So this is the thing that basically we are looking at now. And if different patients need to be looked at differently, for example, if a patient that has a lot of fluctuations in the first days, if he will have a different outcome at the end of the day. So, this is hopefully the future for our patients, when we will be able to establish all this data, and of course also in the long term.
Well, you need to be congratulated for validating the AI. There's lots of discussion about AI, but I think this is the first true validated clinical application.
That's true. That's absolutely true. That's
Fantastic.
absolutely true, and I think that, I mean, all the investigators who've contributed over the years so much to that need to be congratulated, because I think this is the main issue. You have so many AI analysis of everything, especially of OCT, and I think it's really important to know that the validation is there.
In the real world, are you using home OCT?
Unfortunately, because we don't have the monitoring center in Israel, I don't have it available. However, the company now is trying to actually, as I said when I started to talk a few minutes ago, the science is already there. We know. The main challenge is the integration into the health system. And because they want to check the integration to the health
Yes.
system, they're trying to look at Israel as a small, example. So now there is an opportunity where we might be able to use the home OCT not to establish something, because we cannot repeat the large scale studies that were already done, but just to establish the connection to the health system, to the reimbursement, to the compliance, to the adoption of the physicians. So this is mainly what we are doing now in Israel in this regard.
Yeah. Yeah, the integrated care system for wet AMD is very important. And this,
This is exactly what it is. That's why, I mean, I'm so happy that you are saying that, because this is exactly what it is. It's not a machine. It's not a technology. If someone wants to build a cheap OCT and give it to the patients at home, Tsai started on a project and they stopped it. And I guess it's not a problem for any OCT company to build a cheap OCT that will be at the house of the patient. But to establish the whole system of analysis, of the cloud, of the prescriptions, of the compliance monitoring, and all that, this is a little more, this is a big challenge.
yeah. Well, neovascular AMD is a lifetime disease. And
It
it's an
is.
expensive disease to treat. So this integrated approach may very well be the most economically viable way of approaching this disease.
Yeah. By the way, some people are asking, yeah, for the model if because it's a very long-term disease, then will you ever be able to give the machine back? Because the business model is that the payer is renting the machine.
Yes,
And it's a good question. Maybe when you're stop treatment, or for if this ever happens, then it can be an option.
yes, yes. Well,
What
this
I
was,
emphasized in the angiogenesis meeting is, I just mentioned it briefly here, is that the technology tries to differentiate between patients. I just said it briefly in the beginning. When there is a lot of fluctuation, so the trajectory, what they call, is noisy, or if it's a very stable, silent trajectory. And when you look at it and you establish the signal to noise ratio, then you can learn a lot. And apparently, when you look at the signal to noise ratio and you analyze the results according to this, you can very nicely see the sensitivity and specificity, which was very good when you use the signal to noise ratio. It's also good when you use just a population based threshold, but it's even better when you use a personalized score.
well, this was a wonderful discussion, and congratulations on all your great work. It really is
Thank
moving.
you, Carmen. You're so
It is,
nice, really.
it is moving ahead, and I like the concept of this being an integrated delivery system. That's
Yeah,
exciting.
that's what it is. That's what it is.
It is exciting. And at least in the United States, the drugs are so expensive. If this leads to more rational use of the drug, that in itself will economically justify the cost with better
You're
results.
right. You're right. But on the other hand, when you want to bring it to the physicians, um, I don't
Yeah,
want, you know what I want to say.
yes, yes.
There are many things that lead us to treat but I think that as a as a principle, everyone wants to do good.
Good.
Everyone wants to do the best for the patients.
Okay. Well, great talking to you and stay safe.
Thank you. Sorry that you woke up so early for me.
Oh, that's not that's no problem whatsoever.
Thank you.
Okay.
Thank you
Bye-bye.
so much. Bye, Carmen. Thanks a lot.